يسعدنا طبعا ان دكتور محمد حمدي عماره. دكتور محمد حمدي عماره هو ممثل لشركه بايوجين، وهي اللي بيتعمل لها التحاليل في شركه سنتوجين بره في المانيا. وطبعا وجود دكتور محمد حمدي عماره الثلاث اربع سنين اللي فاتوا فرق معايا جدا وفرق مع العيانين in the diagnosis, and he's helping us for the whole exome sequencing. فدكتور محمد every year he will have a lecture on some genetics to explain to us about diseases, what to do, what is the genetic testing. His talk today is about the repeat expansion testing in neuromuscular disorders. اتفضل يا دكتور.
السلام عليكم. شكرا دكتور ناجي على المقدمة. تاني أنا محمد حمدي ريجنال مانجر لسنتوجين. سنتوجين هو جينيتيك لاب موجود في ألمانيا. هو متخصص في الجينيتيك دايجنوزز بصورة عامة، سواء من سنجل جين لبانلز لهول اكزوم وهول جينوم. بالنسبة لسنتوجين هي ان كولابوريشن مع معمل بايوجين هنا في مصر as a sole distributor بالنسبة لها. المحاضرة النهاردة we are going to talk about the trinucleotide repeats في الكلينيكال براكتس النيورولوجيكال والنيوروماسكولار ديس اوردرز. أول حاجة احنا we have to know that في المولكيولر diagnosis there are different techniques used. سواء في السنجل جينز ممكن نبدأ ب sequencing للسنجل جين بطريقة محددة، سواء بسانجر sequencing أو بNGS to detect a mutation in the sequence or small insertion or deletion. في تكنيكس مختلفة زي الميلبا والكيو بي سي ار بتستخدم في detection of deletion duplications على مستوى الاكسنز في بعض الأمراض زي الاس ام اي والدي ام دي. والكور بتاعنا النهارده في البرزنتيشن او اللي احنا هنتكلم عليه اكتر النهارده في البرزنتيشن هو الريبيت اكسبانشن تكنيك. الريبيت اكسبانشن تكنيك normally 30% من الجينوم الهيومن جينوم بيبقى في السيكونس بتاع الجين some triplets repeats بنورمال رينج. النورمال رينج دي اول ما تبقى expanded او بتعدي beyond الرينج اللي موجود ساعتها ممكن تديفلوب a disorder. ودي بنسميها التراينوكليوتايد ريبيت disorders. فالتراينوكليوتايد ريبيت disorders هي a result of abnormal expansion of repetitive sequence occurred during human development causing affection of the nervous system. زي ما كنت بقول لحضراتكم 30% من النورمال جينوم او النورمال هيومن جينوم بيبقى فيه السيكونس ده بطريقه طبيعيه. فونس ان هو يعدي الريبيتيتيف بصوره غير الطبيعيه بتبتدي يحصل فانكشنال او نون فانكشنال بروتين اللي بيظهر على اساسه جين اوف فانكشن او لوس اوف فانكشن. بسي والايدج اوف اونست اوف مانيفستيشنز بالنسبه للديس اوردر. الانهيرتنس باترن بتاع الريبيت اكسبانشن ديزيزز برضه هو من ضمن الايفيدنسز للدايناميك نيتشر بتاع الميوتيشنز. زي ما كنت بقول لحضراتكم بما ان الريبيتيتيف سيكونس موجود بصوره طبيعيه في الهيومن جينوم، فبالتالي مع مرور الزمن كل ما من جنريشن السيكونس دهوت ممكن يزيد لما يوصل beyond certain threshold ممكن ساعتها يظهر repetitive expansion او repeat expansion disorders. Some types of the repeat expansion disorders زي spinal cerebellar ataxia, types of spinal cerebellar ataxia, الفريدرايخ ataxia, fragile X syndrome, الميوتونيك دystrophy, الهانتنجتون disease. دي تايبس من التراينوكليوتايد ريبيتس. ولو بصينا على الصوره اللي جنب الديس اوردرز هنلاقي ان في الطبيعي زي ما كنا بنتكلم ان في نورمال رينج للريبيتيشن بتبقى موجوده، وبعديها في intermediate repetition، وبعد certain threshold بتظهر الافكشن وبيبقى البيشنت بتاعنا affected. الريبيت اكسبانشن احنا هنتكلم على بعض الامراض فيها زي الفريدرايخ اتاكسيا. الفريدرايخ اتاكسيا هي accounts about 50% of the all cases of ataxia. It's an autosomal recessive disorder بتنتج نتيجة ال GAA triplet repeat في او repeat expansion في الفراتاكسين. النورمال individuals المفروض ان هم بيبقى عندهم from 8 to 30 copies. When the threshold exceeds the 30 بتبتدي تظهر او بيبقى في البريماتيور فيز بتاعه الميوتيشن لغايه لما ممكن توصل ل 1000 ريبيت سيكونس من الجي اي اي وتظهر الاعراض بتاعه الفريدرايخ اتاكسيا. الكومن كلينيكال فيتشرز اللي ممكن تقابل حضراتكم في البيشنتس بتاعه الفريدرايخ اتاكسيا ان يبقى في بروجريسيف جيت وليمب اتاكسيا، absent of lower limb reflexes, reduction في اللوس reduction or loss للvibration sense, cardiomyopathy, sclerosis, foot deformity. وفي النيرف كوندكشن ممكن يبقى في absent sensory nerve action potentials. المين سايتس باثولوجي للفريدرايخ اتاكسيا بتبقى في الدورسال روت اوف جانجليا، البوستيريور كولومز اوف ذا سباينال كورد، الكورتيكوسباينال تراكس والهارت. فده اكزامبل من one of the triplet repeats disorders اللي ممكن تتشخص بتكنيك زي التريبلت ريبيت تكنيك. another type هو الفراجايل اكس. الفراجايل اكس هو dominant في الميل أكتر. In the males approximately 1 of every 4,000 may be affected. Among the females approximately 1 in every 8,000 or 9,000 can be affected. This occurs to the triplet repeat في البيز اللي هو السي جي جي في الاف ام ار 1 جين. الفراجايل اكس زي ما كنا بنتكلم ان بما ان كل سيكونس متعدد موجود في الجين ليه نورماليتي، فونس ان النورماليتي رينج دي بتزيد بتوصل للبريماتيور وبعد كده هو ممكن توصل انه يبقى افكتد. فالفراجايل اكس از ان اكزامبل الكومن رينج بتاعه من 60 to 40 ريبيتس، الانترميديت رينج بتاعه من 41 to 60 ريبيتس، البريماتوريشن من 61 to 200. whenever ان ال 200 السيكونس بتاع الجي اي اي exceeding ال 200 بيز بيبقى ساعتها في افكشن. الكلينيكال فيتشرز ممكن تبدا من اول facial features وتبقى دي particularly in females. macroorchidism during or after puberty. About 20% من الميلز ممكن يظهر معاهم seizures، بيبقى فيه macrocephaly، بيبقى فيه affection في الهايت بتاع الميلز. few patients ممكن يظهر عليهم overweight. في الانفنسي بيبقى في affection في الكونكتيف تيشو بتاع الانفنتس، ممكن توصل congenital hip dislocations، inguinal hernia، او في الليتر لايف ممكن تؤدي لسكوليوزس، فلات فيت، او mitral valve prolapse. third type من التايبس من التراينوكليتايد ريبيت ديس اوردرز هو المايوتونيك ديستروفي، وده يعني من اشهر الحاجات اللي ممكن تقابل حضراتكم في الماسكولار ديس اوردرز. المايوتونيك ديستروفي هو ترانسميتد ماتيرنالي بطريقه اكس لينكد دومينانت مانر. اللانس بتاع السي تي جي اكسبانشن ريفلكس السيفيريتي اوف ذا ديزيز وكورليتس للماتيرنال ايج كمان. الحاجات المشهوره في المايوتونيك ديستروفي في البرزنتيشن في الكلينيكال برزنتيشن من اول الانفنسي او حتى كمان من البرينيتال لغايه الادلت اونست ممكن تظهر بريديوست فيتال موفمنت، بولي هيدرومينس. الالترا ساوند فايندنجز ممكن يبقى فيها تالبس، بوردر لاين فنتريكيوميجالي. افتر بيرث ممكن يبقى فيه نيونيتال هايبوتونيا، فيدنج وريسبيراتوري ديفيكولتيز. وبعد كده في التشايلد هود عند سن ال10 سنين ممكن يبقى فيه cognitive و behavioral features disorders. بعد كده في الكلينيك في الكلاسيكال او في الادلت اونست اللي هي بتبقى من السكند للفورث ديكيدز بيبقى فيه symptoms زي المايوتونيا involving specific muscle groups زي الفور arm، الهاند، التونج and the jaw. رابع تايب هو الهانتنجتون ديزيز، وده most likely هو paternal transmission in males with existing prematuration في الجيرم سيلز. اول ما بنعدي من 3 to 175 fold increase في النمبر اوف ذا repeats بتحصل affection. والهانتنجتون ديزيز الكلينيكال فيتشرز او الموست كلينيكال فيتشرز بالنسبه له هو progressive movement disorder زي الكوريا progressive cognitive disturbance و various behavioral disturbances. الامبورتنس في التراينوكليوتايد ريبيتس ان في الكلينيكال براكتس وانس ان انا كفيزيشن عرفت ان البيشنت بتاعي ممكن يكون developing a trinucleotide repeat disorder او repeat expansion disorder، انا مش لازم اروح ان انا اعمل حاجه زي هول اكزوم سيكونسنج او ان انا اعمل سنجل جين سيكونسنج، لان هنا مش هيبقى ليا فايده بالنسبه لي. السيكونسنج ماشينز في العموم بتيجي عند السيكونسز اللي هي بتبقى ريبيتد بصوره كبيره، هي تقدر تقرا النورمال رينجز. اول ما النورمال رينجز بتاكسيد الماشين بتطلع ايرور، فبالتالي الاكسبانشن او التراينوكليوتايد ريبيت تكنيك هو اوريدي ديفلوبد عشان يقدر يقرا الريبيتس اللي هي زياده عن النورمال. فلو احنا كنا بنتكلم ان في سيكونس معين في جين معين زي الاف ام ار 1 للفراجايل اكس او الاتش تي تي للهانتنجتون او الفراتكسين جين في الفيردرايخ اتاكسيا، ونفر ان هو في ابنورماليتي في السيكونس بتاع الريبيتس، السيكونسر ماشين مش هتطلعها لي، لكن التراينوكليوتايد ريبيت اكسبانشن هيطلعها لي. فهنا يجي دور الكلينيشن ان هو كل ما بيقدر يبقى واصل لديفرنشال دايجنوزز وبيبقى عارف الكوريليتد ديس اوردر بالنسبه للمريض هو ايه، يقدر على اساسه يختار تكنيك يوفر فلوس ممكن تدفع في تحاليل ما تجيبش نتيجه، ويبقى السكوب بتاعه رايح لحاجه معينه. دي اهم نقطه ممكن نبقى عارفينها. احنا عندنا في سنتوجين اوريدي بنشتغل الريبيت اكسبانشن از سيبريت تكنيك، وريسنتلي سنتوجين لقت ان من ضمن الحاجات الفيزيشنز بيبقى سيكينج ليها ان هو يبقى الريبيت اكسبانشن كابلد مع سيكونسر تكنيك، لان برضو في بعض الاحيان كوست افكتفنس عشان برضو احنا في ديفلوبمنت كونتريز ما بيبقاش في affordability ولا في purchasing power كويسه بالنسبه للبيشنتس، فبيبقى المريض او الفيزيشن عايز للمريض يضمن له سكوب كبير يقدر يغطي ديزيزز كتير، وفي نفس الوقت يبقى مغطي له كل التكنيكس الافيلبل. عندنا احنا اوريدي ديفلوبد الكيتس في سنتوجين على السنتوجينوم ان هي تقدر مش بس تقدر تقرا السيكونسنج بتاع الاكزون والانترنس بالصوره الطبيعيه، لا هي كمان دلوقتي ديفلوبد ان هي تقدر تعمل كمان تريبلت ريبيتس، وتقدر تطلع التراينوكليوتايد ريبيتس في 23 جينز زي ما هنشوف هنا في الفيتشرز بتاعه السنتوجينوم. السنتوجينومز زي ما كنت بقول لحضراتكم مش بس بيطلع السنجل نيوكليوتايد فاريانتس اللي هو الاس ان فيز والاندلز على الاكزونز والانترنز، لا هو كمان بيطلع الميتوكوندريال دي ان اي او بيغطي الميتوكوندريال دي ان اي، وبيغطي السيكونس بالكوبي نمبر فاريانس كمان. من ضمن الحاجات اللي نزلت عليه في الكيتس ان هو يقدر يطلع اليو بي دي زي مثلا حاجات زي البرادر ويلي او الميثايليشنز المعينه اللي ريبورتد في بعض الامراض هو يقدر يطلعها. الريبيت اكسبانشن وده اللي يهم المحاضره بتاعتنا النهارده ان زاد على الهول جينوم في سنتوجين. الريبيت اكسبانشن هو بيغطي 23 جين، ال 23 جين دول منهم 13 جين بس للسباينال سيربيلر اتاكسيا، لان معظم الاوتوزومال دومينانت سباينال سيربيلر اتاكسيا ممكن يكون ليها علاقه بريبيت اكسبانشن في بعض الجينز. مش بس كده، هو بيغطي كمان الهانتنجتون، بيغطي السي ام بي بي بالنسبه للمايتونيك ديستروفي تايب 2، وبيغطي الدي ام بي كي بالنسبه للمايتونيك ديستروفي تايب 1. فبالتالي انا والاف ام ار 1 بالنسبه للفراجايل اكس، فبالتالي انا كفيزيشن لو عندي بيشنت شاكك ان هو عنده انترونيك ميوتيشن ممكن استخدم هول جينوم. لو شاكك ان هو عنده تريبلت ريبيت وعايز له مش اغطي بس تريبلت ريبيت، اغطي سيكونس لوايد فرايتي من الجينز ممكن اطلب له هول جينوم. لو البيشنت عنده سباينال سيريبرال اتاكسيا وانا عارف ان في 13 جين ممكن يكونوا ريسبونسبل للسباينال سيريبرال اتاكسيا، بدل ما اروح اعمل سيكونسينج بس للسباينال سيريبرال اتاكسيا واروح بعد كده اعمل تراينوكليوتايد ريبيتس لل 13 جين واكلف المريض variable cost، لا انا ممكن من الاول اطلب هول جينوم يقدر يغطي لي all types of ataxia بالسيكونسينج بان جي اس وكوبي نمبر فاريانتس اون بلس، يقدر يغطي لي كمان ايه التراينوكليوتايد ريبيتس اللي موجوده. من ضمن الحاجات برضو اللي نزلت في الهول جينوم ان هو دلوقتي يقدر يشخص الاس ام اي. ان احنا عارفين زي ما كنا بنتكلم في اول المحاضره ان في تكنيكس معينه بتستخدم من ضمنها الميلبا اللي بيكشف على اكزون 7 واكزون 8 في الاس ام اي، وده ما كانش افيلبل في السيكونسنج زي الهول اكزوم سيكونسنج. الهول جينوم النيو كيت بتاعته دلوقتي افيلبل ان هي تقدر تشخص الاس ام ان 1 والاس ام ان 2 بالكوبي نمبر فاريانت اناليسيس، وكمان بيعمل لها كونفirmation بالميلبا. واتس امبورتنت في الهول جينوم كمان ان every mutation detected ليها علاقة بتكنيك مختلف عن السيكونسنج لازم بيتعمل لها confirmation. فور اكزامبل لو حاجة confirmation بتاعها ميلبا يتعمل لها confirmation ميلبا، لو حاجة methylation يتعمل لها confirmation ميلبا، لو حاجة repeat expansion يتعمل لها trinucleotide repeat expansion as a confirmation test. بس فده مين لي المحاضرة. أنا كنت حابب بس أشرح لحضراتكم some triplet nucleotide repeats disorders. الفايدة من وراء إن أنا أستخدم single technique، والهول جينوم جديد وقد إيه هو قدر يinvolve trinucleotide repeat as a evolving technology مع السيكونسنج اللي ما كانتش موجودة قبل كده. شكرا لحضراتكم.
طبعا انا بشكرك جدا دكتور محمد حمدي عماره. and this is the role of clinician to diagnose clinically the phenotype and then to order the suitable genetic testing. So we know now there is 23 genes they are doing for repeat expansion, different diseases. Of course, centogenome is very expensive. I do it when I don't diagnose a patient. But sometimes, if there is the fund is available, it will solve the problem, especially in ataxias, heredofamilial attacks. What I will do the repeat expansion, I will do the whole exome, or I can do a test that can collect other body.
اتفضل يا دكتور.
شكرا جدا لحضرتك. انا هبه راشد، استاذ مساعد مخ واعصاب. انا بس في كذا نقطه عايزه استوضحها من حضرتك، انا ممكن اكون دخلت متاخر فيعني correct me if I'm wrong. اول بوينت تيك هوم مسج بتاعت حضرتك ان احنا ممكن لو احنا عاوزين شاكين في عيان، بس انا مش متاكده قوي احنا بنتكلم في اي inherited disorder، ابعت الاسهل whole genome sequencing، وده هيكفر التريبلت ريبيت وهيكفر الديليشن والدوبليكيشن والكلام ده كله. يعني مثلا عيان فور اكزامبل سي ام تي شاكه بس مش متاكده ان هو سي ام تي مثلا، فده هيكفر البي ام بي دوبليكيشن والكلام ده كله، صح كده؟
تمام يا دكتور. بصي خليني اقول لحضرتك على حاجه يا دكتور. هي الفكره كلها بمنتهى البساطه، انا كفيزيشن ان النهارده قاعد في عياده تمام وعملت الورك اب بتاعي ووصلت الديفرنشال دياجنوزس، ممكن ساعتها اكلم محمد انا عندي بيشنت مثلا شاكك فيه ان هو سي ام تي تمام. هقول لحضرتك ساعتها ان التكلفه ان احنا لو عملنا البي ام بي 22 ديليشن دوبليكيشن باي ميلبا بلس هول اكزوم تكلفته هتبقى اقل من الهول جينوم. فهنا ريزونبل ان انا اعمل كابلنج للميلبا مع الاكزوم وابقى غطيت ان انا عملت الاكزوم وعملت البي ام بي 22. استعوض كده بايه؟ استعوض ان احنا اوريدي عندنا الان جي اس بانلز احنا مخصصينها اوريدي ان هي تبقى انكلودنج الديفرنت تكنولوجيز اللي بتغطي الديزيز ارياز. بمعنى انا مثلا لو النهارده اوفثالمولوجيست تمام وجالي بيشنت انا شاكك ان هو عنده ophthalmology disorder وعايز اعمل له بانل، فانا عندي سنتو فيجن بانل covering the all eye disease. بالتالي انا النهارده كلينيشن نيوروماسكولار تمام، وشاكك ان انا عندي نيوروماسكولار ديس اوردر، ممكن اطلب نيوروماسكولار بانل which is will be cost effective panel ان هي تبقى including البي ام بي 22 بملبا تمام، بلس ان هي including all the muscular disorders بالسيكونسنج مع الكوبي نمبر فاريانتس. فهنا زي ما كنا بنتكلم وجود مالتي ديسبلينري ما بين الفيزيشن وما بين الجيناتيست وما بين اللاب ممكن يوصلنا ان احنا نوصل لقرار في التحليل يبقى افكتيف. وانا عامه لما اي دكتور مثلا بيجي لي بديفرنشال دايجنوزز ما بعرفش عنه، ببقى قدامي حل من اتنين. اول حاجه ان انا اشوف الليترشر عندنا بيقول الكومن ميوتيشنز هي ايه، لان التكنيك هنا ممكن يفرق وممكن يشخص لي على طول من غير ما اروح لحاجه برود. وفي نفس الوقت ان انا ببعت لالمانيا بجيب منهم من الميديكال تيم ايه البروبر تكنيك اللي ممكن استخدمه بالنسبه للبيشنت ده ويبقى كوست افكتيف، وهم بيرشحوا لي 1 نعمل كذا، 2 نعمل كذا، 3 وهكذا.
يا ترى البانلز دي متوفره في الويب سايت بتاع حضراتكم، او نقدر يعني how can we access these panels يعني؟
مظبوط. الويب سايت لو حضرتك دخلتي على الويب سايت بتاعت سنتوجين حضرتك هتلاقي البانلز كلها موجوده تمام، وفي زي اي بوك هم عاملينه على الويب سايت شارحين كل بانل والبانل ايه الجينز اللي موجوده جواها تمام، وايه التكنيكس المستخدمه فيها. يعني مثلا فور اكزامبل حاجه بعيده عن النيورو ماسكولار شويه بس ممكن تقابل حضراتكم في العياده بما ان هي انترفنتد شويه مع الماسل ديس اوردرز، حاجات زي الابيليبسي تمام. الابيليبسي ليها جينز برضو بتتغطى بالديليشن دوبليكيشن فبيتعمل لها ملبا تمام. اوريدي الجينز دي مثلا في الابيليبسي بانل متغطيه، فهم في سنتوجين مش بس خلوا ان البانل تبقى collecting the all disorders مع بعض، لا ده هي مش all disorders، ده كمان different technologies.
بس كل ده في الاخر هيتم ثرو الكونتاكت بيرسون، يعني انا هلاقي فين بقى الكونتاكت بيرسون اللي انا المفروض اكلمه؟ هيبقى حضرتك ولا هيبقى مكتوب على الويب سايت ولا؟
هو لو حضرتك بعت لهم بره هيفرودوا الايميل ليا تمام، ولو حضرتك عايز تكلميني مباشره يعني. تحت امرك يعني.
اوكي. والعيان بعد كده بيجي لحضراتكم تسحبوا له بقى العينات
تمام. انا زي ما كنت قلت لحضراتكم في البدايه احنا اوريدي ان كولابوريشن مع معمل بايوجين وهو موجود في مصر الجديده تمام، فونيفر ان بيبقى في اي بيشنت المعمل شغال 5 ايام في الاسبوع من الساعه 10 للساعه 7 من السبت للاربع. اي بيشنت بيبقى موجود بيروح بيسحب العينه هناك، الدكتور بيبقى كاتب له الكلينيكال ريبورت فول كلينيكال ريبورت بالهيستوري اللي موجوده عنده، ولو حابب ان هو يحط كمان الديفرنشال دايجنوزز وبيبقى في كونتاكت بيرسون في المعمل ان هو ياخد منه الهيستوري دي ويتاكد ان الورق كله تمام ويسحب له العينه. ولو في اي حاجه هو عايز يستفسر عليها في الفلوس في الحسابات يدفع ازاي، يحول على المانيا مباشره ازاي، الحاجات دي كلها دي برضو كلها فاسيلتيز بايوجين عاملاها ان هي تسهل الموضوع. فلوجيستيك وايز الدنيا مفيش اي مشكله فيها. وانس ان حضرتك يبقى عندك بيشنت ممكن حضرتك تخليه كونتاكت مي دايركتلي وانا اديله نمره للمعمل واقول له يروح فين.
كفرد اخر سؤال بقى، كفرد باي انشورنس او كفرد يعني ممكن يبقى لازم اوت اوف بوكيت ولا ممكن يبقى؟
خليني اقول لحضرتك على 3 اوبشنز. الاوبشن الاولاني ان احنا اوريدي متعاقدين مع التامين تبع المبادره على الاس ام اي والدي ام دي تمام، فدي حاجه. احنا عندنا برضو انكلودد في التامين السنتو ميتابوليك بانل وانكلودد في التامين الهول اكزوم. مش كل الحالات في التامين بيتوافق عليها فرانكلي سبيكينج، بس الفكره كلها ان لو البيشنت اوريدي عنده برايفت انشورنس احنا المعمل عندنا اوريدي عنده سجل تجاري بطاقه ضريبيه يقدر يطلع له فاتوره ضريبيه يقدر يحاسب بيها الانشورنس بتاعته يعمل ري امبيرسمنت تمام. فهو بتختلف حسب بقى كل واحد والانشورنس بتاعه شكله ايه والحاجات دي كلها. بس انا اوريدي من الاكسبيرينس بتاعتي على مدار ال5 سنين اللي فاتوا في بيشنتس كانوا بياخدوا فواتير وبيعملوا ري امبيرسمنت من الاماكن اللي هم متعاقدين معاها في التامين.
يعني هو بيبقى الاول اوت اوف بوكيت بعد كده البيشنت يبقى هي ويل جيت ري امبيرسد بقى.
وفي اوريدي ناس بتجيب ابروفلز من شركاتها بتطلع لهم شيكات على اسم المعمل على طول.
شكرا.
تحت امر حضرتك.
دكتوره مي حسين بيدياتريك نيورولوجي كونسلتنت. هو بس سؤال يا دكتور محمد، دلوقتي احنا في تو ريزلتس ممكن يطلعوا لنا ما يوجهوناش في التشخيص، ان انا يطلع لي نيجاتيف ريزلت وان انا يطلع لي فاريانت اوف انسرتين سيجنيفيكانس. حضرتك بتريكومند الهول جينوم لويتش تايب ولا للاثنين؟
تمام يا دكتور، خليني اقول لحضرتك على حاجتين. اول حاجه هو النيجاتيف ريزلتس اللي بتطلع، احنا كل تحليل ليه كلينيكال يوتيليتي. بمعنى احنا مثلا الدراسات اللي احنا عاملينها في سنتوجين على عدد المرضى اللي عندنا دخل لنا اتعمل له مثلا هول اكزوم واصله ل 70%، which means ان انا 7 من كل 10 مرضى بيطلع ليهم نتائج بوزيتيف، حتى لو البوزيتيف دي variant of uncertain significance. تمام. ف 30 اللي باقيين ممكن يكونوا related لريسيرش، ممكن يكونوا related ل undiagnosed mutations. تمام. ممكن يكونوا related لحاجه لسه مش معروفه او حاجه مثلا epigenetic. تمام. فدي قصه اللي هي بتاعت النيجاتيف. القصه الثانيه بتاعت الانسرتين سيجنيفيكانس، احنا اوريدي كل الطفرات اللي عندنا في الداتابيز بيحصل لها تقييم بحاجه اسمها الاي سي ام جي اللي هي الامريكان سوسايتي فور ميديكال جينيتكس. الاي سي ام جي هي اللي بتحط الكلاسيفيكيشن دي بناء على نقطتين. النقطه الاولانيه الايفيدنس بالكورليشن اوف فينوتايبس مع الميوتيشن، وعدد البيشنتس اللي مصاب حوالين العالم. كل ما عدد البيشنتس زاد، كل ما الفينوتايبس كورليتد مع الفاريانت زادت، كل ما بتخليه يروح من فاريانت اوف uncertain significance ان هو يبقى likely pathogenic او pathogenic. طب انا كدكتور لو انا شايف ان الفاريانت اوف uncertain significance اللي هو مؤدي لمرض محدد شايف ان هو متماشي مع الاعراض، ممكن ساعتها اعمل حاجات تانية. مثلا كارير ديتكشن في البيرنتس. ممكن البيرنتس لو عملت لهم كارير ديتكشن على حاجه مثلا اوتوزوم ريسيسيف ولقيت ان هي موجوده في البيرنتس، تمام، ممكن ده يكون 100% ليا اشورد ان ده الكوزيتيف ديس اوردر او الكوزيتيف ميوتيشن. تمام. طيب بناء على كده في بعض الامراض احنا بنعمل لها برينيتال دايجنوزس في سنتوجين ممكن تبقى فاريانت اوف uncertain significance بس اون كونديشن ان يكون الايفيدنس بتاعها الى حد ما اكسبتبل بالنسبه لنا، وان يكون في بارنتال او بيكون في سيجريجيشن في البيرنتس والبيرنتس حاملين للمرض. تمام. طيب انا كفيزيشن شايف ان الفاريانت اوف uncertain significance والنيجاتيف انا عايز يعني further diagnosis، مش مقتنع بيهم. ممكن نروح لهول جينوم، ممكن نروح لهول جينوم. طب اكسبكت ايه؟ اكسبكت ان انا 30% من البيشنتس اللي ممكن تعمل تحليل جينوم بعد نيجاتيف اكزوم او variant of uncertain significance ممكن تطلع بوزيتيف. يعني لو انا بتكلم ان انا النهارده عملت هول اكزوم ل 10 مرضى، 7 طلعوا منهم بوزيتيف و3 نيجاتيف، الثلاثه دولت لو عملت لهم جينوم واحد هيطلع بوزيتيف واثنين will still be negative. فهو have a broader clinical utility او have a broader clinical utility reaching how much؟ reaching 80%. بس هل هو سحر؟ لا. هل هو definitely ان انا لما اعمل جينوم هيخلي النيجاتيف ريزلت بتاعت الاكزوم بوزيتيف؟ لا.
هل بيتعمل periodic reanalysis للهول جينوم او للهول اكسوم سيكونسينج، ولا لازم انا اطلب بعد 2 أو 3 ان يحصل reanalysis؟
احنا هنا هوت عندنا تو روتس. الروت الاولاني based on the clinical evaluation بتاعت الفيزيشن. انا النهارده كفيزيشن جالي مريض عملت له اكزوم، تمام، وطلع نيجاتيف وعايز اعمل له ري ايفالويشن. الري ايفالويشن تبقى بيزد على ان انا كلينيكالي الاقي نيو مانيفستيشن ظهرت على البيشنت، فببعت لسنتوجين واقول لهم there is a new clinical manifestation ظهرت على البيشنت. ساعتها مش هيكلف البيشنت نفس سعر الاكزوم، هيكلف بس الري ايفالويشن. تمام. طيب النقطه الثانيه البيزد نفسها بتاعت سنتوجين. انا دلوقتي في سنتوجين افري كوارتر بيحصل عندي ابديت على الداتابيز. بيحصل ابديت على حاجتين. اول حاجه الكلاسيفيكيشن بتاع الطفرات. لو انا كانت عندي طفره variant of uncertain significance بقت likely benign، ببعت اقول للدكتور البيشنت الفلاني اللي كان طالع عنده فوس في الجين الفلاني بقى من فوس likely benign او من فوس likely pathogenic حسب الايفيدنس بتاع الاي سي ام جي والنيو كلاسيفيكيشن. طب لو انا عندي كانت في طفره في بيشنت والبيشنت هو بعد فتره لقينا الطفره دي بقت باثوجينيك وانكلود ان عندنا في الداتابيز انها باثوجينيك واحنا كنا باعتين ريبورت نيجاتيف، ببعت اقول upon الريفيجن بتاعنا اللي بيحصل periodically البيشنت بتاع حضرتك فلان الفلاني اللي كان ملقوط عنده الطفره الفلانيه بقت كلاسيفايد عندنا في الداتابيز ان هي variant of uncertain significance ان هي بقت باثوجينيك او لايتلي باثوجينيك. ففي جزء احنا بنعمله بس ده ريليتد للطفرات، وفي جزء الفيزيشن بيعمله ده ريليتد للنيو اوتكمز او النيو فيتشرز اللي ديفلوبت على البيشنت.
بس عايزه اكد برضو يعني لما يبقى مثلا patient suspected Becker muscular dystrophy versus limb girdle muscular dystrophy, instead of I'm doing MLPA MLPA dystrophin gene, I can do whole exome sequencing with copy number variant. So here I can see large deletion. The example of Dr. Heba said, if there's Charcot-Marie tooth type 1A, so I'm suspecting a duplication of PMP 22. Can I do at that time whole exome sequencing with copy number variant?
تمام يا دكتور. بصي doing the copy number
because
variants,
of the duplication.
Doing the copy number variants with the whole exome, to some extent you can detect the mutations on the exon level related to the chromosomes, but you will not be 100% sure like the MILPA technique. That's why the MILPA technique is still the confirmatory technique for any large deletions and large duplications. That's why if I'm 100% to be confident 100% for the deletion duplication of the PMP22, I can go for the MILPA technique. Coupled with the whole exome or without the whole exome, I can bear it in mind. So I can start with a whole exome for the patient. Maybe it will be other type of limb girdle, not Charcot-Marie tooth, okay, and he will be diagnosed. If it is negative, I have to include in my mind that I skipped the MILPA technique for the PMP22.
But sometimes Centogene do something good when they found a copy number variant, then they will do MILPA free of charge as a confirmatory.
Yes.
So I have a combo.
Yes, that's true.
Okay.
بشكر حضرتك يا دكتور محمد. الحقيقه تعاملنا مع دكتور محمد كتير، هو يمكن في ادفانتج كمان ان بعد النتيجه ما بتطلع نبقى محتاجين نعرف البانل كانت ايه والجينز اللي كانت تيستد كانت ايه، بنرجع له فيها. هو يعني كان خبر حلو قوي، شايفه الفراجايل اكس دخلت في البانل كمان، الاف ام ار 1 جين.
مظبوط، هو الاف ام ار 1 جين موجود في الهول اكزوم، سوري في الهول جينوم، تمام، بالتراينوكليوتايد ريبيتس، وفي البانلز موجود في سيرتن بانل بالتراينوكليوتايد ريبيت برضه.
بس افهم من حضرتك كده اني لو طلبت الهول جينوم انا هغطي كل الميوتيشنز بتاعه الاف ام ار 1، يعني سواء تريبلت ريبيت او ديليشن او بوينت ميوتيشن.
مظبوط، لانه اوريدي الاف ام ار 1 it will be covered by sequencing with the copy number variants on the normal kit. Okay, and the advanced kit will check the triplet repeats for the FMR1. فحضرتك هتبقي 100% sure that you covered the FMR1 by sequencing, copy number variants, on plus the triplet أو trinucleotide repeats.
Fish scapulohumeral. What about type 1, not type 2? Type 1.
Okay. Do you mean the D4Z4? The D4Z4? The gene related to trinucleotide repeats on the D4Z4? Okay, I have to double check with the lab.
Oh,
I don't know whether it's included or not in the whole genome, so I have to check with the lab. I know that they cover it on sequencing base. But for on triplet repeat, I'm not 100% sure.
طيب سؤال تاني، الاف ام ار 1 ده للبري ميوتيشن ولا للفول ميوتيشن؟ هيطلع لي الفول ميوتيشن؟
Whenever the trinucleotide repeat is done, it will be reported whether it's premature or
اقصد ان هو بيطلع، لان احيانا بتبقى هو هيبقى تكنيك بي سي ار ولا ايه؟ لان هو احيانا بيقولوا لا محتاج ساذرن بلاد، فهنا لحد ايه؟
I have to double check with the technical team because this is a technical issue.
Professor, what about genetic testing of FSHD type 1 or type 2? What are the gene tests needed? Genes and techniques.
So as indicated already with the patient, It is a complex procedure, and we have not even set up that procedure ourselves. So we use a lab in the Netherlands for these testing procedures. But we are, and others are, in the process of trying to take the relevant information out from genome sequencing. I'm not sure there are ready to go protocols yet, but probably there will be.
Because it needs, I think, the DNA to be fresh.
هو عشان الريبيت الفيشوس كابيلوهيومرال they need mainly the southern blot, not the PCR.
And I think the sample was be within certain time, so it will not be denatured, something like that. Yes, must be transferred very rapidly in a good condition.
يعني I think this is a very very technical issue that I have to be checked with the lab.
Many patients.
Yeah.
دكتور محمد، وكل التريبلت ريبيس اللي حضرتك قلتها دي available prenatal diagnosis ليها؟
البرينيتال دايجنوزز افيلبل، بس الفكره كلها ان كل حاجه بيبقى ليها برينيتال ابروفل. يعني الاف ام ار 1 اوكي ابروفد ان هو يتعمل برينيتال، بس upon ان يبقى في حد متشخص وان انا اجيب بس برينيتال ابروفل فيرست قبل ما نسحب الامنيوتيك فلويد.
اوكي، لكن التكنيك افيلبل لو حصل الابروفل
كتكنيك افيلبل
الاندكس يبقى دايجنوزد ونبعت الميوتيشن.
يس يس.
اوكي. هو دكتوره هبه كمان، كنت دكتوره هبه هو بالنسبه لحضرتك لما قلتي الري ايفالويشن، هو فعلا كنا بعتنا حاله وكانت اتبعتت انها انسرتن، بس كانت نفس الميوتيشن في كذا سيب الاخوات. سنتوجين بعتوا لنا اعتقد بعدها ب7-8 شهور انهم بقوا عاملين لي ري ايفالويشن وبقى لايكلي تو بي باثوجينيك. فاقصد ان بالفولو اب بيتواصلوا تاني، بعت لدكتوره ناجيه. في حد عايز يسال حاجه تاني؟
يلا اسئله بسرعه. ها خدي المايك. لا مش هينفع مايك هناك.
السؤال كان ان فارماجين هو بايوجين. لا، هو انا اوريدي as a representative of سنتوجين انا ماضي مع بايوجين اللي موجود في عثمان بن عفان في ميدان اسماعيليه في مصر الجديده. بس فارماجين what I know about them that they are doing like screening, neonatal screening، او بيعملوا حاجات related لانزيمز او حاجات زي كده اهوت على اورجانيك اسيد و سوري. لا لو على الهول اكزوم في ما شاء الله يعني بتاع حوالي 15 معمل ممكن يكونوا دلوقتي موجودين في مصر، بس I'm talking specifically about سنتوجين. ف مش عارف حضرتك اوريدي جربتي معامل مختلفه ولا لا، بس يعني انا اقدر اتكلم عن نفسي انا، بس يعني انا زي ما كنت بتكلم ان الكلينيكال يوتيليتي واصله 70% على هول اكزوم. بعمل هول اكزوم بكوبي نمبر فاريانس وان جي اس وميتوكوندريال دي ان اي. ممكن يكون سعري دلوقتي اغلى سعر موجود في السوق، يعني اي كونفاس حاجه زي كده، بس ستيل يعني اي داوت ان ممكن حد يكون عنده نفس الداتابيس بتاعت سنتوجين، بس ف that's why this for them costs money يعني.
في سؤال هناك بعد إذنك.
في طفل كلينيكالي في مايوتونيا، والمذر برضو عندها مايوتونيا، وفي كلينيكال. هو كده المفروض اطلب له جينيتك ستادي.
طيب حضرتك اوريدي مشخصه الطفره قبل كده؟
لا، هو كم فور ذا فيرست تايم موبايل كلينيكال اكزامينيشن في مايوتونيا.
اوكي.
تيستس اوف مايوتونيا.
تمام.
اوكي. المذر كمان فيها مايوتونيا وفيها المسلز بتاعتهم هما الاثنين فيها هايبرتروفي.
اوكي. فحضرتك شاكه ان هو البيشنت ومامته هما الاثنين مايوتونيك ديستروفي تايب 1 صح؟
تمام.
طيب انا ممكن ساعتها اعمل حاجه من الاثنين. تمام. ابدا الاول بالدي ام بي كي ريبيت اكسبانشن. تمام. اشوف لو هو مايوتونيك ديستروفي تايب 1 ولا لا. تمام. if negative ممكن اروح ساعتها الهول اكزوم. if positive يبقى انا خلاص شخصت.
So if the mother does not have myotonic dystrophy type 1 phenotype, yeah, so then I would suspect this is a case of sodium channel gene mutations which cause dominant myotonias. Yes, if there is no cheaper gene panel containing SNC4A gene.
هو بيقولك اذا كان الفينوتايب زي ما اتفقنا اهم حاجه، اذا في الفينوتايب بتاع المايتونيا ديستروفيكا هنعمل تراينيوكليوتايد ريبيتس، اسم ما فيش فهو بيفكر ده الصوديوم شانل اوتوزومال دومينانت مايتونيا. اذا عندنا بانل، طبعا احنا ما عندناش بانل، فهنا هتلجئي للهول اكزوم سيكونس.
تمام، يعني كده هول اكزوم from the start.
Yes, of course, but depending on whether the mother has a DM1 phenotype or not, because you can't. Yeah.
Doctor, upon your pre-work, okay, and confirming that the mother is a DM1, you can go for the DMPK repeat expansion, okay. If you are not 100% sure.
انا شفتها وعملت لها كلينيكال اكزامينيشن، هي عندها مايوتونيك ديستروفي، يعني الفينوتايبس اللي موجوده عليها هي فيها هايبرتروفي اوف المسلز، وفيها الفيشال اكسبريشنز ماسك اكسبريشنز وال
Okay, so yeah. And just to make things more complicated. Yes. So most dominant myotonias, which are not muscular myotonic dystrophies, are caused by the sodium channel gene SNC4A. But we have exceptions again. So most non-dystrophic myotonias are caused by recessive chloride channel genes, which is very common. And we have families where several chloride channel gene variants are segregating in the same family, causing a pseudo-dominant inheritance. So they are in fact recessive, but in several generations because of the frequency of variants in this gene. So just to make it complicated.
Again, the phenotype is very important. We can also, as a clinician, read about what is the genetics about this disease. We can consult our colleagues in the team of clinical genetics, as I'm doing all the time. And then we can order the proper testing, the most suitable to help us to have the diagnosis. طيب في أي أسئلة تانية؟ الحقيقة هي محاضرات الجينيتكس دايما ممتعة، ومحاضرات دكتور محمد حمدي عمارة بأسلوبه كده الهادي الرقيق، وهو وعدني إن إحنا we will search for these high expenses but very accurate testing. So he will try to help us to have a better prices. إن شاء الله. دكتور محمد عمارة, regional representative of Centogene in Egypt. Thank you so much, and usually with us every year. Thank you. لا خليكي معانا بقى خليكي. And now for the very nice case. Dr. Rana arranging a very nice cases presentation, and I have an assistant lecturer, excellent assistant lecturer حقيقة, دكتورة مها صبري. مها صبري will present a case with differential diagnosis of inflammatory myopathy. احنا على فكرة عندنا وقت ل4 حالات، فالحمد لله حظكم حلو، فممكن نشوف الحالات in details يا مها. يعني احنا عندنا وقت لغاية اللانش اللي هو هيبقى الساعة 4. فا اوكي.
Good afternoon. I am Maha Sabri, Assistant Lecturer of Clinical Neurology at Ain Shams University. I will present the case of Mr. MYAY. He is 49-year-old male, Baccalaureate of Commerce, works as car repair and paint workshop, married with 3 offspring. Youngest is 14-year-old. He was born and currently lives in Cairo. Smoker 1 pack per day for 30 years. Cannabinoid occasional user for 2 years and stopped 25 years ago. Complaint, difficulty in swallowing. Past history, he has recurrent renal stones, experienced since childhood as renal colics. He underwent laser lysotrophy 10 years ago and controlled currently on medical treatment with no complications. He also has chronic gastroesophageal reflux disease since 1995 with chronic use of proton pump inhibitors until now. Was complicated by acute exacerbation 4 years ago. The patient underwent upper GI endoscopy twice. Was 4 and 2 years ago, which revealed sliding hiatus hernia, antral gastritis, and healed duodenal ulcer. And he was positive for H. pylori, for which he received medical treatment and responded. 2 months ago, he was complicated with hematemesis after low-grade fever with no symptom determining source of infection then, with no hemoglobin drop, and he was hospitalized and controlled on proton pump inhibitor infusion. He has past history of hypothyroidism, accidentally discovered 6 months ago during laboratory workup for his current condition. He is currently compliant on L-thyroxine 50 milligrams and controlled upon follow-up. Patient has received COVID-19 vaccination 4 years ago and no other significant past history. He has normal developmental history. The family history, no consanguinity. He has family history of neonatal deaths. One of them was provisionally diagnosed lysosomal storage disease after genetic testing. He has family history of recurrent early abortions. He has a strong family history of malignancy, runs especially in paternal side. 3 of his aunts, paternal aunts has breast cancer, and the uncles has hepatocellular and splenic carcinoma, and 1 uncle has colon cancer. He also has a strong family history of gastritis and renal stones. He has family history of Graves' disease and ulcerative colitis. Also family history of epilepsy, psychiatric disorder, and alopecia, all these 3 symptoms in 1 family member. He also has family history of diabetes, hypertension, and ischemic heart disease. No family history of the same condition. This is the family pedigree. This is our patient, and his his nephew died at 7 months old and diagnosed by genetic testing as lysosomal storage disease. He also has another nephew that died at 1 month age but undiagnosed and recurrent abortion. This is his nephew. Abnormal facial features and bone abnormalities, but he passed away, and this is the genetic testing. Yes. Accidental family pedigree.
Who did this family pedigree? Extended وبالالوان، انا اول مره اشوف بيديجري بالالوان، ده جميل قوي قوي. اتفضلي.
Can I explain or pass the slide? Doctor, explain okay. This is our patient. He married with his cousin, which has Graves' disease. None of his offspring has significant neurological disease. Just his son has food allergy, and his brother married his maternal cousin with offspring described before in the short pedigree. Here is gastritis run in the maternal side, and the cancer and renal stones mainly runs in the paternal side. And he is the son with epilepsy, the relative with epilepsy, alopecia, and psychiatric illness. His parents are consanguineous. No other significant history here. History of present illness. The condition started with a gradual onset, progressive course of 2-year duration. 1 month after the patient underwent upper GIT endoscopy, when he started to have difficulty in swallowing more 4 solid particles associated with recurrent choking and nasal regurgitation of both solids and fluids, together with nasal intonation of voice and difficulty in speech. There was no emotional lability, no urinary incontinence. Meanwhile, he started to complain of neck muscle weakness with tendency of neck to fall forward, up to the patient uses his hand to support his head upward so that he can see in front of him. The patient sought multiple medical advice and misdiagnosed as esophageal adhesions and underwent balloon dilatation for esophagus with no improvement of dysphagia. 4 months later, the patient noticed that he can't close his eyes firmly, together with inability to drink using a straw and inability to whistle or blow, and decreased facial expressions, and this was noticed by his family, decreased the amplitude of his smile, and so on. There was also decrease in his volume, voice volume, pitch, and resonance, up to the degree that the speech became effortful and slow. Meanwhile, the patient started to develop bilateral upper limb weakness, asymmetrical left more than right, proximal more than distal, extensors weaker than flexors, associated with generalized decrease in muscles bulk. There was also decrease of tone around the shoulder, elbow, and wrist bilaterally. The weakness was up to the degree that the patient can't raise his hands above his head. There was no fasciculation. 5 months later, he developed inability to get up from recumbent position without support. Meanwhile, he started to have trouble in breathing on exertion. 5 months later, he developed bilateral lower limb weakness of the same distribution of upper limbs, associated with generalized decrease in muscle bulks. There also was decreased tone around the hip, knee, and the ankles bilaterally. The weakness was up to the degree that he found difficulty in standing up from a chair and climbing stairs, but he still walking unsupported. There was no fasciculations. All through history, there was gradual progressive weight loss, about 40 kilograms, and there was also gradual progressive darkening of some exposed skin areas unlike his usual. Patient sought neurological advice, underwent investigations, and kept on low-dose oral steroids, mycophenolate mofetil, and pyridostigmine, but with no improvement. All through history, there is no fatigability, no diurnal variation, no ocular or mastication muscle affection, no muscle pain or cramps, no myotonia, no sensory affection, no autonomic or urine color changes, no epilepsy, no other system affection. Formulation: the patient is 49-year-old male smoker with past history of chronic GERD associated with H. pylori infection and complicated with gastritis and duodenal ulcer. past history of renal stones and hypothyroidism, and the family history of lysosomal storage diseases, recurrent abortion and the early neonatal deaths, family history of malignancy and the autoimmune disorders such as gastritis, ulcerative colitis, Graves' disease, alopecia, family history of epilepsy and the psychiatric illnesses, and family history of renal stones. Presented with gradual onset, progressive course over 2-year duration of dysphagia to solids, bulbar symptoms, axial and proximal muscle weakness associated with significant weight loss and excessive hyperpigmentation. General examination, the patient is generally cachectic and he has a hyperpigmentation of sun-exposed areas compared to baseline photos. He also has inability to lying flat, but not due to respiratory affection. This decubitus is his baseline since 1995 due to acid reflux. 4 years ago. He also has adequate diaphragmatic movement on tidal percussion and scaphoid abdomen. On neurological examination, the speech is slow monotonous with occasional nasal intonation of voice. He has weak orbicularis oculi, orbicularis oris, and the weak vaccinator, diminished gag and bladder reflex, and he has shoulder and neck drooping. On motor examination, there is generalized atrophy, but no fasciculation, no tenderness, no myotonia. He has decreased tone around the upper and lower limb joints. He has bilateral asymmetrical upper and lower limb weakness, more to left, proximal more than distal, extensors more than flexors, abductor more than adductor. He has winging of scapula and the truncal muscle weakness and the waddling gait. Intact coordinations. Deep tender reflex elicited all over, and he has bilateral extensor plantar response. No sensory affection except for dermatomal affection on left L2, L3 distribution. No stretchy signs, no other significant neurological signs. The investigations, these laboratory investigations, the normal CBC and the electrolytes and the INR even on follow-up. Normal, negative virology, normal hemoglobin A1C on annual follow-up. His thyroid profile shows around the double increase over 1 year. In 2022, it was 4.3. And in 2023, it was 7.2, and the lab, the test was done in the same lab and the same reference range. He has low vitamin D, which improved on supplemental medications. He has increased sustained CKs, normal alkaline phosphatase, and high LDH, normal lactate. Normal ESR on annual follow-up and negative CRP, negative anti-nuclear antibody, normal carcinogenic embryonic antigen. The neurophysiological studies done, he underwent repetitive nerve stimulation of bilateral facial nerve 1 year ago, showed positive myasthenic reaction. Yes.
What about the EMG? At that time they didn't do EMG.
He did EMG on the right deltoid and the left quadriceps muscles and showed no abnormalities. November 2023, 1 year ago. But the repetitive nerve stimulation was on facial nerve. Oh, okay. This is the repetitive nerve stimulation of facial nerve. Yes, of facial nerve. Exactly. Oh, yes. Maybe artifact. Yes, yes. This is the EMG of deltoid muscle. تمام. He underwent needle EMG and nerve conduction study and repetitive nerve stimulations for right and left orbicularis oris, lower cervical paraspinals, and right deltoid and right biceps, and bilateral extensor digitorum and abductor digitoid minimi, and left vastus medialis and gastrocnemius tibialis anterior and the extensor digitorum brevis muscle. It shows myopathic picture with negative decremental response.
انت عندك السيكي عادي، السيكي كنا فوق ال1000 يعني، فطبعا expected ان يبقى فيه ان شاء الله يعني مايوباثيك، لكن ما لقيناش الديكريمنت. ده اللي هو المركز الثاني. اتفضلي. نيرف كوندكشن نورمال. ما الديكريمنت از اوكي والنيرف كوندكشن نورمال.
The panel of inflammatory myopathy was negative. Alpha 1,4 glycosidase was normal, and THMGC receptor was negative, and the acetylcholine receptor antibodies was negative.
So according to this, no inflammatory and no antibody for acetylcholine receptor antibody. Okay, next. He
underwent the whole body MRI about 1 year ago. Apart from suspected right thyroid lobe nodules, the MRI showed a mild bilateral, nearly symmetrical muscle edema of multiple muscles with distribution as in the table.
You have the MRI.
الأفلام بس باظت من الشمس فكان سايبها في العربية.
Okay, the MRI films are not good. There is some sun exposure, so we have only the report. بس احنا ممكن to order to ask the radiology department when this was done.
عين شمس University Specialized Hospital.
Okay, when?
1 year ago. December 2023.
We can ask. Okay. Sometimes they are still have the الCT او بيبقوا عندهم، فممكن to ask even if you will pay a small payment to have
reprint
the reprinting. Okay, so there is edema. You said there is edema.
Mild bilateral symmetrical edema, yes. Mainly in biceps brachial.
But there is affection of leg muscles. هاتي كده الصفحة اللي قبلها يا مها. So what is on the right is edema. What is the left is fatty infiltration. هاتي اللي بعدها يا مها. So now we have edema in the leg muscles and also in the biceps brachii, and there is no fatty infiltration.
Yes.
But we have to see the films. Okay. Next.
The muscle biopsy didn't show any inflammatory or dystrophic changes. There was only some fibers that showed increased BAS activity. The impression was glycogen storage myopathy for genetic testing.
And he did the genetic testing?
No.
Not yet. So we didn't find dystrophic changes exactly like the MRI. We didn't like inflammatory changes. And only there was some fibers with periodic acid shift. So no inclusions. I was thinking also about rimmed vacuoles, but there is no.
Just many conflicting results.
And CK is high.
Variable outcome of the neurophysiological studies, some telling yes, some decrement, others no decrement. And we have clear heavy weakness starting in the bulbar area and then spreading towards limbs. Yeah. When I first heard your first words on this with the bulbar problem spreading to the neck area, I thought this is probably a Miller-Fisher type of CIDP in the nerves of the head region. But the high CK levels are not really. And but EMG results were also not consistent. There were different results here and there. Yes, yes, but that does not exclude this type of Miller-Fisher problem. It does not necessarily. But I think the only very conclusive data are the high CK levels, which are not compatible with direct neurogenic lesion. Of course, you can have high CK levels in some neurogenic conditions like Kennedy's disease, and also in rapidly progressive nerve defects. But that you should see on EMG. So I'm a bit confused, to say the least, what this could be. I would definitely, to do EMG in the tongue is not so bad as it sounds. I would really like to know what happens in those bulbar muscles. And these were not, and I did not see anything on the neck muscles either.
No.
Yes, I understand. But apparently there was no tongue atrophy.
No, there was no tongue atrophy.
But the bulbar problem was sort of the most problematic for the patient from the beginning, and very complicated. Of course, we can't exclude by this information we have, we cannot exclude a very extraordinary inflammatory myositis type of condition, but I have not seen bulbar starting with myositis. So again, we have different information, and they are not consistent. So we are in trouble with having any clear ideas what could be going on.
Mitochondrial disorder.
Well, this type of bulbar
and
neck can be there, but the eating choking problem, I have not seen that. But
you are seeing something about Kennedy. What about Kennedy?
No, it starts in the lower So what can we do to make something more clear? I didn't see the location for the biopsy.
We have
Where was it taken?
Taken from the biceps. Sarah, Fatima biceps.
Left biceps, yes.
Okay, and
there was edema in the biceps.
and we
Inflammatory changes in the biceps.
yeah, and nothing on pathology. Yes, but everything always you can have unusual things, but yeah, maybe we have some better ideas.
Okay, we need help. We need ideas about this conflicting case, and we have the patient. Okay,
Doctor,
order the patient to come, please.
I work in pediatrics, and I think the diagnosis fits cystinosis, familial cystinosis. Yes, it's a lysosomal storage disease with high cystine level. It can affect the renal. There is nephropathic and non-nephropathic. It can affect the renal. It can cause GIT disorder. Most patients has hypothyroidism, and it has muscle weakness. I'm not sure about the CBK level, but I think this diagnosis fits all the. It's autosomal recessive.
He has a nephew with lysosomal storage.
Yes.
So this is a very, very good idea.
Cystinosis, familial cystinosis.
How can we prove
I think we have to go for genetics. I'm not sure. But I think it's more of renal. We can ask renal physicians, or I think ask the lab how to diagnose.
He has loss of weight. So
It's a good idea. I know of a combination of muscle weakness and cystinosis, but only in terms of distal limb weakness, which we have seen. But there are different forms of cystinosis. So this could be something else.
I think they also have swallowing difficulties in cystinosis. I think.
Yeah. Yes, but that is one issue. But you see, in this type of pedigrees, where you have multiple levels of consanguinity, you will have many homozygous genes segregating. So there can be several disorders.
We have to revise. Is there any biochemical testing we do, or only we have to refer to the genetic diagnosis?
This
So-
is a pedigree, doctor.
Yeah, no, the genetic study. نعم.
أستاذ محمد.
هي دكتورة نرمين برضو رأيها ان احنا ممكن ناخد رأي الفريق الميتابوليك جينetics. We have a metabolic team. So yes, we have to ask them. But this can collect the hypothyroidism, the GI troubles, and the loss of weight, and also this positive family history. You are completely right. We have to search about this. This is the patient. تعالى يا بابا. أنا شفت العين ده معاكم صح؟
Yes, you patient.
شفته معاكم. عليكم السلام، ازيك؟ أخبارك إيه؟ عامل إيه؟ إن شاء الله بخير. اتفضل يا حبيبي. تعالي يا ما.
Yes, you can see the generalized muscular wasting all over, of course more severely shown in the head region, and can you open your mouth? Yeah, and out with the tongue. So no clear atrophy in the tongue, despite the very severe bulbar weakness with eating. What does he have to choose what he is eating, or does he eat everything? What is can he eat everything?
No solids. He has difficulty and must drink with each piece of food.
And he loses weight all the time?
Yes, he was 90 kilogram. Currently, he 50 kilo only.
And during the last year, how many kilograms did he lose weight?
آخر سنة بالضبط يا أستاذ محمد فقدت قد إيه من وزنك؟ About 30 kilograms.
And you can hear the dysphonia. He has difficulties to pronounce. It's a bit nasal, and suggesting that the whole system in the bulbar region does not work correctly. Can you make? Yeah, and
الزر على عينك جامد كان يكون صابون.
So it's weak all the time. And can you so mildly some movements but not very strong. Okay.
افتح دقنك تحت زق على دي. جز على اسنانك. Okay.
So it is definitely also more proximal than distal, but generalized in a way. So we will just see if, okay, just relax. Barely elicitable. reflexes, so not gone and definitely not increased. Can you stress?
I think as the left biceps reflex has some discrepancy from the right. So
We will see.
more increased.
No, no. The reflexes also much depend on the activity of the patient, and so you can have different responses in different situations. But these are barely elicitable, so weak reflexes all the time. What more should we test? We could test if you bend down. Yeah, keep. So very weak, and backwards. There is some strength, yeah, but still you see the posture. So generalized wasting, starting basically with the bulbar problem, and without clear evidence of neurogenic atrophy and mechanism, no clear evidence of inflammatory background, and no clear evidence of any specific type of disorder affecting bulbar region. So yes, some unusual. I have not seen this before.
He has also bilateral extensor plantar. I don't think it's bilateral extensor. Yes. Yeah.
Yes, proximal weakness in the lower.
Yes.
حضرتك مسؤولة عن الحالة، أنت كاتباها خلاص، أنت كاتباها خسارة. جمعي الكلام ده اكتبيه وهنسأل هناخد رأي نتابعه. شوف الدكتورة بتاع الولد الله الله الله
More normal than upper limbs, but upper limbs have started earlier with these are definitely not elevated responses here. So no sign of upper motor neuron involved.
This is a very, very, very interesting.
Happy to have the final results at some point.
I hope so. والله اللي هي مش هيك.
I found the positive family history of his nephew was has a homozygous mutation in mucolipidosis. Yes, but I found here that persistent elevated CK and lysosomal storage myopathy associated with mucolipine 1 defect. I know. But facial, yes.
Phenotype.
يعني شفتوا الحالات بتبقى صعبة ازاي، وممكن يبقى very rare disease، ممكن يبقى new syndrome، ممكن يبقى ماها syndrome، محدش عارف. بس يعني I think that these cases are very interesting and the patient deserves to complete the case investigation, not only for research purposes. No, we are patient-centered and we want to know what is the diagnosis to help him, if there is a treatment or even genetic counseling. Thank you, Yamaha, so much, and I'm waiting the result. If he will need genetic study, tell me, we can try to have some funding for him. Okay, I have to introduce another one in the neuromuscular team. حبيبي it's my pleasure to introduce Dr. Nuran Mohammed Sabri. Nuran is assistant lecturer Ain Shams University in the neuromuscular unit, and she will present a case with a differential diagnosis myasthenic disorder versus mitochondrial disorder. تفضل يا حبيبي.
Good afternoon. I'm having a light case.
Take your time. We will ask you.
Mrs. SRG, 47 years old female patient, born on 20th of January 1977, married with 4 offsprings, born and lives in Shobra al-Khema, Egypt, works at a school. She is right-handed, perimenopausal with no special habit of medical importance. Complaint, dysphagia with nasal intonation of voice. There is no family consanguinity. She's having a nephew who's having her same symptoms, which started at the age of 30 years with rapid progression of symptoms all across 1 year. The family pedigree. This is our patient, Sania. This is her nephew. She had intrauterine fetal death once and 1 abortion. Otherwise, no other thing significant. No surgical history and no developmental instance. History of present illness, gradual, progressive, of 14 years duration. The condition started 14 years ago with a change in the patient's voice in the form of nasal intonation with no diurnal variation and no other pulpar symptoms at that time. She sought medical advice and was diagnosed as a palatal problem, and she had a palatal surgery for palatal repair with no improvement. Patient was stationary with only nasal intonation for 11 years. 3 years ago, the patient started to develop ptosis in the right eye, followed by the left eye with diurnal variation. Ptosis increase at night. Not far away, patient developed dysphagia more to solids with nasal regurgitation to liquids with difficulty of mastication and chewing foods. At the same time, she started to notice a change in her smile and inability to show off her teeth while smiling, along with inability to totally close her eyes, noticed during washing her face with soap and during sleep. 2 years ago, patient was admitted to ICU for 2 days with ventilation due to respiratory problems. No other data available at that instance. She didn't receive any plasmapheresis or IVIG at that time, nor pulse steroids. 1 year ago, patient started to develop diplopia, seeing 2 objects beside each other with accounting on slowing of movement of one eye at sometimes occasional squint, with no account on degree of maximal separation of a diplopia. Also, 1 year ago, patient started to develop proximal more than distal muscle weakness in both upper limbs and lower limbs at rest and increases markedly with exercise. Up to patient cannot stand from sitting position or climb stairs easily, along with decrease in the muscle bulk in both shoulders and proximal upper limbs. All through history, patient was on pyridostigmine and low-dose steroids with very mild improvement of symptoms, only regarding dysphagia and ptosis. No remarked exacerbations or remissions, and patient didn't receive any other modality of treatment. All through history, no other motor, sensory, cranial, sphincteric, autonomic fits, nor fasciculations, nor myotonic changes. There was nothing abnormal during general examination, neurological examination, cranial nerves. Patient is having bilateral ptosis on the right more than the left, increases with fatigability, and limitation in adduction of right eye. There is weakness of muscles of mastication with a temporal atrophy. bilateral facial muscle weakness or poikilaris oris and oculi, tongue muscle weakness bilateral with tongue deviation to the right, no tongue fasciculation, lost gag with centralized uvula. There is atrophy in both proximal upper limbs, shoulder girdle muscles and deltoid. Power, mild bilateral upper limb and lower limb proximal weakness, grade 4 to 4+, and increases with fatigability. No distinct distribution. Reflexes, lost reflexes of both upper limbs and lower limbs. Gait, there is mild waddling gait. No sensory abnormality. That's it.
What's your opinion يا نوران؟ يعني انت الحالة كده وفي positive family history، انت فكرتي في ايه؟
First of all, we were thinking of myasthenia gravis as a patient started with nasal intonation, with pulpar symptoms, then ptosis, and with diurnal variation. After which, condition is complicating, no certain exacerbations, no myasthenia actually most probably comes in attacks.
Remissions and exacerbations.
Yes, that doesn't happen with our patient, and she didn't improve markedly on pyridostigmine nor low doses steroids. So we are thinking of something mitochondrial.
And you said something, there was atrophy of some muscles?
Yes, there is atrophy.
Which muscles?
Shoulder and deltoid.
Reflex change? Lost. So,
yes.
There are some similarities with the previous patient.
Yes.
And I guess the parents, so this was also a consanguineous family?
Non-consanguineous. No.
Okay, I interpreted the pedigree wrongly. I thought the parents, okay.
No, non-consanguineous.
So it's just by chance.
No, it's another line.
No. Okay.
Yes.
Yeah.
The symptoms of her nephew, I didn't see him. He is traveling abroad, but she said that he developed all the symptoms across 1 year.
So
he's also having 30 years, 37.
37.
Yes.
37.
Yes, many of the early symptoms go towards myasthenia, but diplopia is usually not seen in myasthenic problems. So this is something else, clearly. And you probably have neurophysiological studies?
Yes. She has done nerve conduction EMG twice, both during 2022. The first one showed myotonia, and the second one showed positive decremental response.
This is the importance of neurophysiology.
Yes.
What is the CK?
She lost her investigations.
So this is not the first time we see very divergent EMG studies. One shows this and another shows something else. And it is, of course, an indication of all quality not being good enough. Yeah. But the myotonia should be seen on the on the next study. It can't disappear.
Usually different from hand to hand.
Yeah.
If I hear it once or I see
Yes.
the once.
Yeah. So we need some better studies on this, definitely.
Okay.
Yeah.
Okay.
And also again some neurophysiological studies on the involved bulbar muscles.
Also muscle biopsy here.
Yes, good. Yeah.
Because we have to search also
Yeah.
for mitochondria.
Yes, and always, of course, we need muscle MRI to see what is the mechanism of muscle weakness.
Can we see the patient?
Okay. You have the patient. المريضة
هي جاية هنا.
جاي. Her walk is affected, some waddling gait, and several years. بقالنا قد إيه duration?
14 years.
14 years without remissions and exacerbation. So it looks like a stagey, gradual, and very slowly progressive condition.
Does she lose weight?
She didn't account on this.
Okay.
Body weight.
So you can see the weakness in the face. Not all only ptosis, but you can see also in the lower region.
facial affection.
Yeah.
ازيك عاملة إيه؟
Yeah.
تمام. في bilateral facial.
Here the intonation is not good enough. Can you?
قولي اسمك كده بالكامل.
ثانيا ومنهم هما
أنت بتشتغلي ولا ست بيت؟
ما اشتغل
بتشتغلي إيه؟
فني وسائل مدرسة.
تمام.
And can she now eat everything, or does she only
عاملة زي
eat?
بتوع الأوكلوفارينجيال ماسكولار ديستروفي كده.
She's having difficulty in eating solids and nasal regurgitation with liquids.
So very similar to the previous one. And open the mouth.
في معاكي نورين. في أتروفي؟
No major atrophy of the tongue, and no fasciculations in the
No.
tongue. Can you pull out the tongue?
حركي.
Yeah. Okay. So not any clear sign of clearly neurogenic atrophy to account for the weakness. So this is something else, of course.
What about oculopharyngeal muscular dystrophy? It has this voice of the same intonation,
Yes.
very gradual, progressive.
But you usually have in company, the age is also a bit early. She has the symptoms for...
Starting from 37 years.
Yes, so okay, OPM, so and so, usually a bit later. And together with bulbar symptoms and ocular symptoms, you usually have a more proximal leg weakness and not this type of weakness. So
to be considered.
not really the first.
Okay.
Okay, so. But she does not have the same degree necessarily of muscle atrophy as the previous case. Okay, we don't see that, but you...
and he has this waddling gait. She has some waddling gait.
Yes. And so, yes, so grip. So clearly weak, considerably weak, and you say all reflexes were lost, more or less. And we just confirm that.
طبعا reflex change against myasthenia. There must be affection of muscle or nerve, not neuromuscular junction.
So severe degree of muscle weakness, not necessarily accompanied by the same degree of muscle atrophy. In the previous case, we had severe atrophy, but of course in ladies with a bit more subcutaneous fat, it is sometimes difficult to clearly make the distinction. So without that distribution of subcutaneous tissue, it might look a bit different. So we will take a look at the eyes. Can you? Okay. So.
يعني يمكن الاكسترا اوكيولار ماسلز معقوله اوكي not so bad but the ptosis and bilateral facial
and there is also limitation
at the extremes but usually in mitochondrial chronic progressive external symplegia the globe is fixed.
Can you
So this is
backwards.
not the same.
So she is much stronger in the neck than the previous patient. And forward. Here is more weakness. And not much of power. And down with the arms. It is much better. Okay, almost good. And pull. So not that weak.
خلي ايديك لفوق، خلي ايديك لفوق، خلي ايدك لفوق. قومي ماشي؟ لا قومي كويس، قومي كويس.
So not that weak as the previous patient was much weaker, but otherwise some interesting similarities. So we need a lot more information what is going on.
Lab, MRI,
but these are,
biopsy.
to me, both cases are unusual.
Okay, so
so
this is your responsibility.
There is some genes in your population that do not occur in my population. But we will
maybe Nuran syndrome.
wish to have the final solution. Yes.
اوكي طيب احنا الدكتوره نوران هتكمل لك الابحاث اللي فاضله. الاستاذ طلب لك ابحاث هتكملها لك. If there will be in the expenses we can try to help in the genetic study ونكمل كل حاجه ونشوفك ان شاء الله. كله تعب واحد. She has proximal weakness in the lower limbs also. بتعملي علاج طبيعي ولا لا؟ طيب علاج طبيعي بقى وادويه وحاجات كده ونكمل لك حاجتك ان شاء الله. وانتي ديبريسنت. She looks very depressed. She looks very depressed. Yes. اوكي تبقي كويسه ان شاء الله. يعني الحقيقه هي very interesting cases. Thank you يا نوران. بس الخدمه اللي احنا نعملها للعيانين وطبعا للساينس يعني ان احنا الحالات دي لازم نكملها لان استكمال اتفضل يا عصام استكمال الحالات هيساعدنا في التشخيص. دكتور عصام.
I would probably try to exclude the OPM mutation.
No atrophy, no marked atrophy.
No, but I would. There are some peculiar case reports with OPM. There is it's an expansion disease, but the normal range of expansion, if I remember correctly, is something between 9 and 12 repeats. But there are unusual cases with much higher number of repeats, and then the phenotype goes worse. So I would consider that as well.
Of course, that's why the CK level and the muscle biopsy is important to know about oculopharyngeal muscular dystrophy, to know about mitochondrial myopathy, other dystrophic changes. Yes, before Isam will start first. Before going to any genetic intervention, to know. And the MRI muscles, of course, because we must know, we will do a trinucleotide repeats, we will do a whole exome, what we will do first. Isam al-awwal?
My question, to conclude in such a patient, is it mainly neurogenic or myogenic? She has lost reflexes, she has lost gag, and no very much weakness and atrophy of the muscles to cause lost reflexes. My question, what's your opinion? It's neurogenic or myogenic, such a patient?
شكلك انت اللي هتعمل EMG ان شاء الله. He is expert in neurophysiology. You repeat the nerve conduction, EMG and technical.
So this type of ocular and bulbar weakness are unusual for a neurogenic disease and would indicate a lower motor neuron engagement and then you would see tongue atrophies and fasciculations in the tongue. We did not see that. Neurogenic background, even the Miller-Fisher syndrome is sort of less likely. Something else than clear lower motor neuron in background.
Okay, thank you.
I usually prefer that the team will do the nerve conduction EMG again. So after you order the lab, including the CK level, please ask Dr. Isam to help again. If you can do also genioglossus, it will be very nice to see this is myogenic or neurogenic. Another question here. في سؤالين. يلا. استني. اسمك ايه؟
سهى.
سهى تاني؟ طيب سهى assistant lecturer neurology. تفضلي.
Doctor, I would like to ask if it is reasonable to add anti-mask as a differential diagnosis for the patient. Being female, facial affection, pharynx, poor response على البيروستجمين.
Yes, you are right. She is asking if we must order also for anti-mask antibodies.
In this type of case, it's difficult to know where to go. I would just do everything possible to have some ideas for yourself.
اسمك ايه بقى عشان اتلخبطت؟
رنا.
رنا بتشتغلي فين يا رنا؟
لا برايفت سيكتور نسام.
انت قلتي لي الحكايه دي الصبح وانا طبعا نسيت. انت نيورولوجي اصلا؟
نيورولوجي وبيدياتريكس يعني.
اوكي. نيورولوجي وايه؟
بيدياتريكس.
Excellent. تفضلي انا.
I think in this case I would like to go out of the box like the previous case. I think this is more a systemic disease rather than only neurological. I was wondering if we can consider the diagnosis of scleroderma given the swallowing difficulties and the small mouth. I didn't examine the patient, but if she has tight skin, maybe you can consider scleroderma plus extraocular manifestations. I think there are some papers published about scleroderma with diplopia due to extraocular muscle affection. And there are some papers about scleroderma with neuropathy. I think that can explain both the patient's symptoms.
Rana. So Rana also is thinking of an autoimmune disorder. We didn't see the nephew. We don't know what he has. So she's thinking about something like scleroderma. Sometimes it can be mixed disorder, scleroderma, myasthenic symptoms. There is some reported case of I think this is an excellent thinking. So we must consider فين نوران عملت حاجات نوران autoimmune. She didn't do. You have a great job to do.
So as before, in these unusual problematic cases, just do whatever you can think of.
Yeah. Any other questions? عشان نوران ما عملتلهاش حاجة لسه. Okay, thank you, ya Nuran. You have a lot of work to do with this patient. And next speaker will be Dr. Samar Samir Farhat. Samar is one of the very active and neuromuscular specialists. Was a resident with us, but now a great work in the sea. You are in the Hurghada, in the sea, in the insurance. So she has doctorate degree in limb girdle muscular dystrophy, and now we'll present a patient with hereditary sensomotor polyneuropathy versus distal myopathy, and this is a very important differential diagnosis.
The patient مش ولا واحدة من دول. معاكي على واتساب يا دكتور. Good evening. I am Samar Samir. Okay. Miss S.H.M., 18-year-old female patient, born and lives in Matruh, single, second-year computer science student with normal performance and average intelligence and no special habits of medical importance. Complaint, bilateral upper and lower limb weakness. Family history, third-degree consanguinity, no similar condition or congenital malformations in the family. Perinatal history uneventful, developmental history normal motor and mental milestones. Past history, blocked tear ducts at birth, improved on medical treatment, ASD 6 mm, spontaneous closure. Family pedigree, second degree consanguinity. The patient had a younger sister who died at the age of few days, after birth of few days. And there's 3 abortions the second trimester. History of present illness. The condition started with gradual onset, progressive course of 18 years duration since the patient's birth. The patient was born with prematurely aged appearance, wrinkled skin, abnormal scarring of wounds, droopy facies, and prominent veins of distal upper and lower limbs. The patient's skin and joints also had the ability to be stretched beyond their normal range with abnormally long and slender fingers and toes, in comparison to hand palm and foot arch. When the patient started walking, the family noticed her frequent falling that became more frequent over the following few years. At the age of 10 years old, patients started to develop bilateral lower limb weakness, proximal more than distal, left more than right, affecting hip flexors more than extensors, knee extensors more than flexors, with no account on further distribution. That was associated with hypotonia around hip and knee joints and atrophy of bilateral gluteal thigh, feet, and leg muscles to the degree that she became unable to climb stairs at her school without unilateral support. Over the following few months, the patient started to develop inability to move her joints through their full range of motion. She also started to develop difficulty in rising from recumbent position, with increased lower limb weakness to the degree that she became unable to walk without bilateral support. This part improved. This was for a little time, then improved to now she can walk with the unilateral support. Few months later, the patient started to develop bilateral upper limb weakness, proximal more than distal, shoulder abduction more than adduction, elbow flexion more than extension, with no account on further distribution, which was associated with hypotonia around all upper limb joints and atrophy of bilateral hand and forearm muscles. All through history, there was no diurnal variation, no fasciculations, cranial nerve affection, cerebellar autonomic or sphincteric affection, no affection of conscious level. No myoglobinuria, relation to heat or cold, no cramps or history of exercise intolerance. General examination, she's now 18-year-old, but this picture was for the features, the prematurely aged features. Patient is vitally stable, general appearance, progeroid facial appearance, bilateral leg and forearm atrophic scarring, arachnodactyly, contractures of wrist, knee, ankle, and proximal interpharyngeal joints of left fourth finger and right fourth and little fingers. Neurological examination, patient is conscious, attentive, oriented, speech, no dysorthy or dysphasia, cranial nerves were normal. Motor system state, atrophy of bilateral gluteal thigh, leg, feet muscles, bilateral forearm and hand muscles. Cough pseudohypertrophy needs further examination. Tone couldn't be assessed due to contractures. Power, bilateral lower limb weakness, proximal more than distal, left more than right, knee extensors more than flexors, hip flexors more than extensors, abductors more than adductors. Plantar flexion equals dorsiflexion, bilateral upper limb weakness, proximal equals distal, shoulder abduction more than adduction, elbow extension more than flexion, with trunk muscle weakness or positive Gower sign. Coordination is intact, lost deep tendon reflexes all over, superficial bilateral flexor plantar, waddling gait, and bilateral high glove and stopping hypothesia. Investigations, CPK level was 880, that's the highest level, repeated many times. The average is 600, 400. Very high level of LDL and total cholesterol, AST and ALT mildly elevated, vitamin D3 is 8, was repeated, was 16, parathyroid hormone was high, total calcium was 7. Autoimmune myopathy panel was negative, malbadystrophin was negative, whole exome sequencing was negative. Normal thyroid function, anti-thyroid antibodies, anti-CPA and rheumatoid factor, CRP, alkaline phosphatase, serum protein electrophoresis, kidney function, coagulation profile, electrolytes, protein create ratio, urine analysis, urine protein, LDH, amino acids, and homocysteine. MRI muscle showed bilateral symmetrical fatty infiltration with no evidence of muscle edema, proximal more than distal, lower limbs more than upper limbs, affecting the following muscles: deltoid, subscapularis, infrascapularis, latissimus dorsi, and paravertebral group, anterior abdominal muscles, pectineus, adductors, gluteus maximus, medius, both extensor and flexor groups of thigh. Extensors, quadriceps is more affected, especially vastus lateralis, with mild affection of medial head of gastrocnemius. Muscle ultrasound showed muscle fatty infiltration in the form of reduced muscle bulk, increased echogenicity at the following muscles: bilateral quadriceps muscle with relative sparing of vastus medialis, bilateral gastrocnemius, bilateral hand hypothenar muscles, upper arm forearm, no significant reduced bulk, بس كان في increased echogenicity. Nerve conduction EMG studies in 2022, right tibialis anterior, left rectus femoris, and right gluteus medius showing profuse denervation potentials, at rest positive sharp waves, fibrillation potentials, complex repetitive discharge, and polyphasic small short motor unit potentials, picture suggestive of myopathy. Was repeated in 2024. Profuse myotonic discharge associated with myopathic motor units, a picture of myotonic muscular dystrophy affecting proximal and distal muscles in both upper and lower limbs. كان في polyneuropathy بس مش مظبوط يعني. Wrist and hand ultrasound, mild bilateral synovitis in both wrist, right third and fourth distal interpharyngeal joints. Bone mineral density was normal. Leg X-ray, small bone island in left tibial shaft. Normal fundus examination, normal MRI abdomen, normal EEG, echocardiography, and CT brain. Differential diagnosis.
What is the problem about this case? Why Dr. Nermin asked you to introduce this case?
We have connective tissue skin manifestations at birth, then myopathic pattern.
She had these pre-senile features?
Yes.
It is like progeria. Dr. Nermin, this is a very difficult case.
Exome sequence was done as research work in a private lab. It's not as Centogene or something like that. The condition that she has, we think about the gyrodermia because she has since birth the redundancy of the skin picture suggestive of connective tissue or something like cutis laxa or something like this, but the association with myopathy, it was strange. Yes.
Like denervation potentials, like as if it was neurogenic. But now myotonia, so.
My
But the muscle biopsy, there is atrophy.
No muscle biopsy. It was Ultrasound.
So yes, the muscle MRIs show clear myogenic and a bit diffuse, not very, to some degree. Yeah. So, and here also.
Mainly in the side, mainly gluteal and side.
So some peculiarities with medial gastrocs, which are highly hypertrophic. So they are almost gone.
So she has capsule hypertrophy.
Hypertrophy.
Hypertrophy here.
It was
evident.
It was evident لما كانت child. It was evident when she was a child. Now.
That's why someone ordered milk
dystrophin.
They thought it would be a carrier.
My first impression is that this should be a this should be a laminopathy. Should be a laminopathy.
Laminopathy.
Of course, the exome should take LMNA gene, which is the main cause of laminopathies, with the progeria, with the skin problems, with heavy joint contractures, and the myopathic condition. So my first idea in this case would be to ask the genetic lab if they had full coverage of that gene or not, and if there are some and contractures and some skin.
And the skin changes. So this is a very good, that's why maybe Dr. Nermeen want to speak about this patient. يعني هم فاهميهم الحالة بس عشان هم مش فاهمينها. تعال يا حبيبي. يعني هي she has features as if more senile than her mother. The patient is on the right side and the mother on the left. But there is a feature of senility. هي عمرها قد ايه دلوقتي؟
18 years old.
Yes, of course. She is 18 years old. And she has this muscle disease, gradual and progressive. And she has this skin changes and joint changes.
Very relevant point. A paper published a few years ago by Dr. Meloni and the Mayo team, and they found that patients with laminopathy, they have accelerated aging, and they found correlation between their biological age on ECG with the artificial intelligence, and there was a gap between the biological age and the chronological age.
Yes, so we have severe atrophies. Not so much maybe proximal in the arm, but clearly, as you can see in the hands, all small muscles are more or less gone. And you can see the long fingers also sometimes observed, and then the fixed contractures. Difficult to bend, yes, it hurts. So, yes, so, and grip. So compared to the loss of muscle, the strength is there. So, and that's why she manages without too much of external help. So we have a look at the face and follow the eyes are quite normal, and close the eyes very firmly. Yes, good. And open the mouth, and there is nothing much. Out with the tongue, yes, okay. So that looks fine. So just keep, and there's good proximal strength, and extend. So much more weakness in the extensors as you indicate. And you can feel the heavy atrophy, especially of the
Yes.
distal parts of the quads. The muscles are more or less gone. And you can see also on the legs.
Atrophic, marked
they
atrophy.
look much more atrophic
Yes,
than what you will see
yes.
on the MRI.
The muscles are atrophic quadriceps and the leg muscles. So this is true muscle disease.
Okay, it hurts.
And there is contracture of joints.
All over. Not especially in the calf, but and not in the elbows.
Yes. Sparing the elbows.
There is some in the wrist, but compared to the fingers, it is much less. So, how much help does she need in daily life?
She needs only support on climbing stairs,
On moving.
on moving unilateral support.
The mother is helping her in everything, sir. Mother is helping her. But her intelligence, she's highly intelligent. كلية ايه ولا مدرسة ايه؟
Computer science.
Computer science, excellent degree. ها؟
AI. AI.
Artificial intelligence ده اللي هيودي الكون كله في داهية.
The computer. Yes, that's. What about the progression of the disease? Are you much different now?
The redundant ask much for me that the redundant skin was since birth.
Okay.
تودي له ظهرك بس ده مش هنصور هنا. ستوب.
Redundancy market on the back and on the abdomen.
Okay.
دوري كده ودي ظهرك.
She told me that it appears that she has double breast.
It looks like a fat.
Yeah.
The lip. And this is, of course, yeah, lipo atrophy. Yeah. And this is heavily compatible with that. Of course, here it's opposite. So maybe a new variant in that gene would be. Yeah, yeah.
She said Dr. Oud will diagnose lipoatrophy, okay? So,
Very good.
what we'll do?
So yes,
Jeanette,
check
hold
first.
exome.
Check first with the lab that did the exome whether this gene is fully and well covered.
I think no, it was
Laminopathy.
search for some
Okay, so do a new Usually, lamin element A gene is well covered in exomes, but of course you can always have unusual situations where exomal sequencing does not take all problems in a gene. If you have intronal variants that cause missplicing, then you can have something else. Yeah. Good.
I think this year every case is a case report. We started to have abnormal cases. So the last case today will be with Dr. Hussein Hamouda Hassan, Assistant Lecturer, Neurology, Ain Shams University. He also has a last patient of mitochondrial versus congenital myopathy. No.
Assalamu alaikum, good evening. I'm Hussein Hamouda, assistant lecturer. Ali. I will talk about Mr. ALA, 20 years old, male patient, born and lives in Giza, studying second year computer science, single, no special habits of medical importance, right-handed, complain gradual progressive exercise intolerance. This is the family degree of the patient. Family history, no family history of similar condition, history of bipolar disorder in father, history of essential tremors clinically diagnosed in paternal grandmother, history of essential tremors in father's maternal grandfather, history of bipolar disorders in father maternal uncle, history of optic atrophy in father maternal cousin, and history of schizophrenia in father's paternal uncle. Past history, neonatal ICU admission of the patient for a few hours after cesarean section, past history of lactose intolerance, and past history of valvular heart disease related to history of present illness of the patient and on propranolol. The history of present illness started with gradual onset progressive course of 20 years duration. It started a few years at the age of few months when the patient showed delayed developmental milestones in the form of delayed ability to sit unsupported, crawling, and stand up, as the patient was able to stand up at the age of 1.5 years after seek consultation and was recommended to do physiotherapy sessions. At this age, patients start to show rhythmic to and fro movement of post lower limbs, being of high frequency, low amplitude, postural, symmetrical in post lower limbs, increasing by stress, and disappear during sleep. At the age of 3 years, similar involuntary movements in post upper limbs with same description as in post lower limbs. Patient was observed to have relatively increased arm span, joint range of motion could reach beyond usual limits, and decreased body weight. Condition was slowly progressive regarding involuntary movements, and the age of 6 patient was experiencing exercise intolerance with no diurnal variation and no account on weakness in a specific region. Through the following years, patient was experiencing slowly progressive increase regarding this exercise intolerance, yet no account on weakness. At the age of 19 years, patient was discovered to have skeletal deformity in the form of increased cervical curvature backward and deviation of the dorsal part of the vertebral column to the right. Through the following 5 years, patients start to experience gradual progressive upper limb weakness during performing fine hand movement as opening bottle of water. Also experience difficulty in getting up from component position. At the age of 18, also the patient started to experience dysphagia, more to solids with no nasal intonation or nasal regurgitation of fluids. Also, he experienced fatigability and no shortness of breath even during speaking and after slight exertion. And these symptoms of dysphagia and shortness of breath increased in the last year. All through history, there was no diurnal variation, no fasciculation, no muscle ache, no cranial nerve affection, no sensory, cerebellar, autonomic, sphincteric affection, and no affection of conscious level. General examination. Patient was vitally stable, no lymphadenopathy or organomegaly, no lower limb edema, bony deformity in form of cervical kyphosis, dorsal scoliosis to the right, and high arched palate, no nerve enlargement by palpitation, no contractures. Neurological examination, a patient's conscious, attentive, oriented, no dysarthria, cranial nerves all are normal except for weakness of bilateral buccinator and bilateral and orbicularis oris. Not mentioned here, sorry. State no fasciculation, في generalized atrophy. Patient body weight is 39 kilograms. Hypotonia in both upper limbs and lower limbs. The muscle power. Here are the affected muscles, and the all over distribution is showing pyramidal distribution, being distal more than proximal, and extensors more than flexors in the upper limb, and flexors more than extensors for lower limb. Associated with truncal muscle weakness, as no neck muscle weakness was shown in examination. The coordination was intact. Involuntary movements showed bilateral upper limb and lower limb postural tremors. The reflexes in the upper limbs was no diminished. Lower limb was brisk. Bilateral flexor plantar, index superficial abdominal. Pathological reflexes was negative, and sensory examination was intact. The investigations done, nerve conduction EMG was done twice, showed myopathic pattern. ESR was normal. TSH thyroid profile was done for having low body weight and was normal. CBK was 36. Vitamin D3 was done twice and was sufficient. Serum lactate 14.1. Anti-endomysium antibodies and anti-glycine antibodies and tissue transglutaminase antibodies were done and were all negative. Echo was done for the history of for having marfanoid features, arm span in relation to his lens, body lens, and the history of joint, abnormal joint range of motion. Echo showed mitral and tricuspid valve prolapse and patent foramen ovale with minimal left to right shunt. Pulmonary function test was done for the history of shortness of breath and dyspnea upon exertion, showed mild to moderate small airway disease. The MRI cervical spine, dorsal spine just showed the abnormal skeletal, showed the skeletal abnormalities with no neural compromise or cord compression. Thank you.
يعني تمام الحالة fully investigated except we didn't have genetic study yet. So what do you think? What is your provisional diagnosis?
The patient was between being mitochondrial disease for having systemic affection in the myopathy for dysphagia to solids, pyramidal distribution of weakness, marfanoid features, the postural tremors, versus being just congenital myopathy, but the against is the systemic manifestations or other system affection, and the patient is here.
تمام. والمارفينويد features دي ما تخليناش نفكر في حاجات تانية في الكولاجين أو كده. دكتورة نرمين هتقول لنا رأيها في الحالة.
We found that the patient كان عنده tall stature و skeletal marker of Marfan وفي cardiac manifestations, but the most characteristic is the generalized tremors. We found that with wasting. Sometimes we found sometimes the fibrillin one in the muscles may be يعني affected, so it at the level of the extracellular matrix, so it may affect and induce myopathy with Marfan. But we don't know what is the cause of the tremors, generalized tremors.
I guess there were tremors in the family as well.
Yes.
Yeah, so difficult to say. I mean, the tremors can be sort of not related to the neuromuscular condition. I mean, if there is essential tremor in the family, that can go in a separate line, and they do not need to be combined to belong to the same disease. So what examinations do we have? Do we have any more bio biopsy or MRI or?
Sorry, no MRI muscle or muscle biopsy or done yet.
Yeah, okay. But this is a congenital problem?
Since birth, yes, since birth.
With some progression.
Gradual progression is slowly progressive over 20 years.
Yes, but not very rapid.
Not rapid at all.
And what the capacity of moving now for the patient?
Fully ambulant here is a patient, but experiencing fatigability.
Okay, so what distances can he move?
He can move. Can off.
So can you walk? I mean, it does not look very bad. How long distances can you move?
تقدر تمشي قد مسافة مثلا لحد ما تتعب. محطة مثلا 100 meter or 200 meter.
Okay, okay, so. Mm-hmm.
في kyphosis, cervical kyphosis.
Yes, yes. Yeah. Okay. Yeah.
By examination, flexors.
Oh, strong.
Full
strength. I mean, what you immediately see is the unusual stature, the height, the thinness, and so it's more like a syndromic pattern, to me at least, and not specific myopathy. So the muscle part is probably just one issue in a context of a syndrome.
Doctor, can I ask about the pyramidal distribution also in the context of the syndrome? The
So
pyramidal distribution of weakness in
I mean, you more or less see what is weak. The weakness is not comparable actually, or he is not so weak as what it looks like. I mean, there is hardly any muscle at all, and still he has a grip. You see, the strength is reduced, but compared to the muscle bulk, it's fairly good. But you feel the tremor all the time, all the way. Is there any tremor in the facial region as well? Yeah. So you have that. Yes, I would expect. It's a generalized form of tremor and not just the hands. Again, something very spectacular for me. I have not seen this type of problem.
This is Dr. Nermin.
Yeah.
This is Dr. Nermin.
And again, reflexes compared to the muscle bulk are normal, more or less. So definitely not a neurogenic mechanism, but just loss of muscle bulk.
Yes.
And we would be very interested in seeing a muscle biopsy because I would guess there is more or less only type 1 fibers in the muscle and
Reflexes, preservant.
Yes.
And even brisk.
Even compared to the muscle bulk.
So this is against
And,
neuropathy.
there is some, of course, central mechanism because of the heavy tremors, which are activated when you sort of physically you extend the leg. It's unusual to have tremors in the leg, and he has generalized tremor also in the facial region. So definitely part of the syndrome. and not just normal essential tremor in the fingers, but something else. Yeah. But reflexes to a plantar on the feet. Yeah.
Bilateral flexor. Flexor.
What about the jaw?
Diminished, not brisk.
Open just slightly.
But he has high arched color?
Yes, high arch.
Skeletal deformities?
Yes.
Kyphosis?
And and dorsal scoliosis, cervical kyphosis and dorsal scoliosis.
Dorsal scoliosis and cervical
kyphosis.
Very many tissues and organs involved. We have the brain, we have the skeletal part, we have the muscle part, heart to some extent, yes. But again, what happens in 1 year? How much has his changed over 1 year?
More weakness.
More weakness?
And the breath weakness.
Okay. So could you walk half a kilometer 1 year ago?
Hardly.
Hardly.
Very hard.
Yeah, but
Now it's impossible.
yeah. So from every year it goes down a bit.
Yeah.
Okay.
I was weak and still.
Yeah.
Like more weak.
Yeah. Yeah. Okay. But of course, as I used to say, for all this is a more syndromic issue, but used to say to all my muscle patients with weak muscles have difficulties to perform physical exercise, use your head. As long as the brain is working.
It is.
Yeah. Yeah, so
we have to complete the case, MRI,
muscle biopsy.
Of course, this is a good case for exome study. Anyway, so try to search for.
I found. Dr. Odd, you agree with our thinking that it may be a case of Marfan syndrome, for example, or Marfanoid features with myopathy due to the affection of the fibrillin at the level of the muscle, and this is the cause of the myopathy and weakness. And the tremors is a part of the case, or is another trouble that run in the family?
I thought first when I heard the family pedigree that this was just a part of a second problem, a benign distal tremor in the family, but this tremor is different.
Yes.
This tremor is generalized, it's more heavy all over, so it's part of the brain.
Disease. Okay. Okay. Thank you.
طيب يعني شكرا يا آدم، معلش تعبناك معانا، بس إن شاء الله هنكمل لك الأبحاث بتاعتك. دكتور حسين حضرتك مسؤول تكمل له الأبحاث بتاعته، وإذا كان كده هنعمل الأول ال MRI muscles الأول ونشوف which muscle we will take from it، عشان كمان إحنا محتاجين نعمله fiber typing كويس، وبعدين نطلب له بعده ده دكتورة نرمين هتظبط له بقى التحليل الجيني بتاعه، وهنبلغ برضو بروفيسور أود بالنتائج دي برضو. شكرا يا حبيبتي. طيب احنا يعني we succeeded، وده عمره ما بيحصل كتير لكن الحمد لله حصل. We succeeded to finish in our time and thank you all for your patience, your effort today. Thanks Professor Odd and all speakers and case arrangements. I hope the presenters to continue investigations for these patients. Maybe next year they will give us the results. So the last thing we'll ask about the lunch, is it a lunch box يا أمان ولا هيبقى هنا ولا إيه؟ هيبقى هنا؟ Okay. So now we have to finish our day. There is a lunch box for us, and tomorrow we will meet at what time? We will meet at 9 because we have a lot of work. And Dr. Sarah must come before 9 without disasters, okay? So, okay, thank you all and see you tomorrow. Thank you. It was nice.